Very good afternoon. We are planning to now go ahead with the second part of recent advances in evidence-based medicine with regards to neonatology. So today I shall be talking about the other systems that we did not cover on the first session. So let's begin with nutrition, enteral nutrition, which is another domain where we have had a lot of advancements. So one of the important advancements in the area of enteral nutrition came with the SIFT trial. Now, the SIFT trial was a randomized controlled trial which looked at So the SIFT was a huge randomized controlled trial which looked at around 2,800 babies who were born preterm below 32 weeks of gestational age. And the idea of the study was to compare slow versus rapid advancement of enteral feeding. So SIFT trial looked at these two arms, and the slow feeding arm was defined as feeding increment at the rate of 18 ml per kg per day, whereas the rapid increment arm looked at increment of feeding at 30 ml per kg per day. So we can see that this was a large randomized controlled trial which was done to answer this question. And the interesting part was 1/3 of infants in the SIFT trial were extremely preterm, and another 1/3 had extreme low birth weight, that is, birth weight was less than 1,000 grams. And SIFT trial also included babies who had umbilical Doppler abnormalities like absent or reversed end diastolic flow in the umbilical arteries. So based on this study that compared these two arms, it was clear that there was no difference in the incidence of necrotizing enterocolitis between the two arms, the faster and the rapid increment, the slow increment arm. The NEC incidence was 5% in babies who had rapid increment in feeding versus 5.6% in the slow increment arm. So there was no statistically significant difference in NEC, whether we increased feeding at 18 or at 30 ml per kg per day. But what was significant was that there was definitely a decrease in the duration of total parenteral nutrition in the trial from 11 days to 9 days in the SIFT trial. And likewise, the median length of intensive care stay was trending towards reduction in the faster increment arm. There was also a reduction in the incidence of microbiologically proven late onset sepsis from 31% in the slow increment arm to 29%. So it was clear that if we incremented feeding at 30 ml per kg per day, there was no difference in the incidence of necrotizing enterocolitis. And this was true even in group of babies who are at highest risk of NEC, such as babies who are extremely low birth weight, babies extremely preterm, or babies with umbilical Doppler abnormalities. Now, we may wonder whether this evidence is also relevant for the Indian subcontinent, but this study from Lady Hardinge Medical College, performed by Dr. Sushma Nangia ma'am and her team, actually showed that in 180 stable preterm babies who were born between 28 to 34 weeks and with birth weights of between 1,000 to 1,500 grams, it was actually possible to begin with early total enteral feeding. So in this randomized controlled trial, the study investigators decided to start early complete enteral feeding in stable preterm babies. And in other group, they started to begin with conventional enteral feeding, beginning with 20 ml per kg per day and augmenting by 20 or 30 ml per kg per day as per the standard practice. But this study was limited to babies who are more than 28 weeks, as you can see here, more than 1,000 grams, and babies who did not have any umbilical Doppler abnormalities. So this Indian study also was similar to the SIFT trial in terms of finding that the early enteral feeding arm had a lot of favorable outcomes. There was not only lesser incidence of feeding intolerance as well as clinical sepsis, 26% versus 61%. There was also a reduction in culture positive sepsis 3.3% in the early total enteral feeding arm, and 8% in the conventional enteral feeding arm. Surprisingly, unlike most trials that do not find any difference in necrotizing enterocolitis, the early total enteral feeding group actually found lower incidence of NEC in the group of babies who had early total enteral feeding. We had another large study that was published in the journal Neonatology in 2019, which also looked at the similar concept, like the Lady Harding study. So this study included babies with a median gestational age of 31 weeks and with a median birth weight of 1,323 grams. The study compared outcomes in babies who were randomized to receive either early total enteral feeding or conventional enteral feeding with increasing augmentation. So this study again showed that there was no difference in the incidence of necrotizing enterocolitis, 1.1 and 5.8%. And there were some other beneficial outcomes, such as, the incidence of NEC stage 2 and 3 was similar, 1.5 and 3%. And there was no significant difference in most of the other outcomes, including mortality and sepsis. So the study again showed us that it is possible for starting early aggressive total enteral feeding in stable preterm babies. Like with the earlier studies, again, the study showed that it is possible to reach full feeds early at 7 days versus 10 days in the group of babies who had received early total enteral feeding. So these are some common questions that are asked in the exams. Probiotics are most useful in the reduction of. Recent trials have shown that probiotics are not only useful in the reduction of necrotizing enterocolitis and all-cause mortality, but also in the reduction of late-onset sepsis. Name the organisms that are the most studied in probiotics. So the organism that has been extensively studied is Lactobacillus GG. Now, species-specific or strain-specific data in probiotics is evolving, and some early recent data shows that Lactobacillus strains are useful in reducing NEC. Both Lactobacillus acidophilus and lactis. Abundant prebiotic that is present in human milk is human milk oligosaccharides or HMOs. The cellular mediation of necrotizing of inflammation in NEC is mediated by Toll-like receptors 4, TLR4. So TLR4 antagonism is being proposed as one of the most important mechanisms for counteracting necrotizing enterocolitis. Now, dose-dependent effect of mother's own milk is present with NEC as well as with sepsis. Now, a more recent systematic review that was published in the year 2017, which included 30 RCTs as a meta-analysis, as well as the Cochrane review that was updated in 2020. Both these have examined the role of probiotics in preterm infants. So the three outcomes with which probiotics are significantly associated are the reduction in necrotizing enterocolitis, definite as well as the advanced NEC, as well as all-cause related mortality and infection. Now, there has been work being done on which is the ideal strain of probiotics to prevent NEC. And in this context, it has been seen that combination of multiple strains, like combining multiple strains of bifidobacterium or lactobacillus, along with Saccharomyces, this combination strategy might be more useful with a odds ratio of 0.36, which indicates 64% reduction in necrotizing enterocolitis. When compared to single-strain probiotics, multi-strain probiotics seem to be more effective. Single-strain lactobacillus-based probiotics also had borderline effect on necrotizing enterocolitis with an OR of 0.60 or 40% reduction in NEC. And they had no effect on mortality. Now, when it comes to a combination of lactobacillus and at least one strain of bifidobacterium species is very preferable. And lactobacillus DG alone may also not be effective. These are all recommendations made from multiple trials of probiotics. When it comes to the ideal dose of probiotics, a dose of 3 into 10 to the power of 9 organisms or 3 billion organisms per day, preferably given in a single dose, is found to be the most effective strategy. And likewise, 1.5 billion coliforming units per day until reaching 50 to 60 ml per kg per day feeds is also found to be effective. Now, when it comes to when to start probiotics, the ideal time to start probiotics is when the neonate is ready for enteral feeding, preferably within the first 7 days of life, because by the end of 7 days, there is considerable dysbiosis that sets in, and then it might be difficult to actually continue to administer probiotics. Now, when it comes to the duration of usage, probiotics are recommended until around 28 days of postnatal age or until 34 to 35 weeks of post-conceptional age or until discharge. And stopping supplementation during acute illnesses like necrotizing enterocolitis seems to be recommended. So this is one study that was published in January in this last year that looked at strain-specific recommendations on probiotics. And this study found that a combination of 3 strains of bifidobacterium, that is bifidobacterium longum, bifidum infantis, as well as lactobacillus acidophilus, may reduce all the 3 outcomes of interest, which are mortality, sepsis, and NEC. But because of the limited number of studies that use this specific combination, the evidence was uncertain. A single probiotic species in the form of bifidobacterium lactis may reduce the incidence of both mortality and NEC. So, so far we've been discussing about the early advancement of enteral feeding as well as about probiotics. We will now move on to recent literature in the area of human milk fortification. Now, we all know that multi-component fortification is recommended in preterm very low birth weight babies, that is babies less than 1,500 grams who are receiving mother's own milk or donor milk. This is because of the reason that the recommended macronutrient recommendation requirement of as well as micronutrient requirement in a preterm VLBW baby in the form of the ESPGHAN recommendation is not met with even with maximal intake of human milk. So even despite maximal intake of 180 ml per kg of exclusive human milk, the recommended calorie, protein, as well as carbohydrate, as well as micronutrient requirements may not be met. So even when we give 180 ml per kg of human milk alone without fortification, knowing that 100 ml of mother's milk contains around 65 to 67 calories, the calorie intake is around 120 calories per kilogram, which is just around there when it comes to the recommended intake, which is 115 to 140. But it is way too less to meet the protein demand. So in comparison to the recommended protein allowance, which is 3.5 to 4 gram per kg per day in a preterm VLBW baby and up to 4.5 gram per kg per day in a ELBW baby, the actual protein content that is delivered with fortified EBM is only 2.5 gram per kg per day. So this is also true for most of the micronutrients. So unfortified human milk, even at maximal daily intakes of 180 ml per kg, falls short in most of the micronutrient intakes with the exception of vitamin C. So these are updated ESPGHAN 2022 recommendations for the micronutrient intakes. It recommends a similar dose of vitamin A, 1,330 to 3,330 international units per kg per day. Vitamin D at 400 to 700 units per kg per day. But the ESPGHAN recommends to keep it below 1,000 units per kg per day. And vitamin K, this is the recommended RDA, 4.4 to 28 micrograms per kg per day. Zinc, the ESPGHAN recommends 2 to 3 milligrams per kg per day. So none of these are actually met with unfortified human milk. Hence comes the benefit of fortification. So we know that multi-component fortification with human milk fortifier has been a strategy that we have all been following for many years now. And why do we use fortification? It is because it corrects most of these intakes, both macro and micronutrient. And when we look at the evidence of use of human milk fortification, the use of fortified human milk has resulted in better short-term anthropometric gains, including a better weight gain of 1.76 gram per kg per day more in babies receiving fortified human milk versus unfortified human milk, as evidenced from 14 randomized controlled trials, including 951 participants. Fortified human milk fed preterm infants had also better mean linear growth, as shown by better length gain as well as head growth. So length gain was superior by 0.12 centimeters per week, and better head growth at 0.08 centimeters per week. The mean MDI or mental developmental index as well as motor and psychomotor developmental index was not necessarily better in human milk fortified infants. So there were no benefits in the long-term neurodevelopmental outcome, whether or not we gave multi-component fortification. But there were definitely short-term anthropometric benefits. So these small gains in short-term anthropometric parameters may also be important for us because achieving better weight gain, better head growth, and better linear growth in the first few days, that is within the NICU stay, may facilitate early discharge in these babies. And we are able to provide this without a difference in NEC or without increasing the risk of NEC. So the absence of long-term neurodevelopmental improvement need not discourage us from using human milk fortification in this group of babies. So the significance of this benefit can be as much as an additional 50 grams weight gain in a baby with a birth weight of 1,000 grams over a period of 4 weeks. Although per day, the difference seems to be very minuscule at 1.76 grams per kg per day. Over a period of time, this seems to be better. So what do guidelines say with regards to fortification? The World Health Organization recommended that the VLBW babies who are fed with mother's own milk or donor human milk should not be routinely given bovine milk-based human milk fortifier. VLPW infants who fail to gain weight despite adequate breast milk only should be given human milk fortification. So here the committee, the SPECAN committee advocates the use of human milk for preterm infants as standard practice, provided it is fortified and with added nutrients wherever necessary to meet the requirements, recommending an energy intake of 110 to 135 cals per kg per day and protein intake of 3.5 to 4.5 grams per kg per day. So guidelines are a little divided on using human milk fortification. While the WHO guideline routinely doesn't recommend the use of bovine milk-based fortifiers, it still does recommend the use of fortification in those VLBW infants who fail to gain adequate weight when fed with adequate volumes of breast milk. Whereas other guidelines recommend routine use of human milk fortification in order to achieve the optimal intake of calories and proteins. So having seen the benefits of fortification, there are various approaches to fortification, starting from standard fortification, which is the traditional technique of adding a standard quantity of fortifier or quantity of HMF to a standard volume of milk. So usually this is recommended by the manufacturers, and most solid fortifiers that we have in India have 1 gram sachets that need to be added or mixed with 25 ml of human milk. Now, despite being practical, it doesn't solve the problem of protein undernutrition in VLPW infants because of the variations in protein intake of human milk. So newer approaches include the use of individualized human milk fortification methods, wherein we can use either adjustable fortification or targeted fortification. So what is adjustable fortification? Here, the adequacy of protein intake is monitored by blood urea nitrogen estimation, BUN levels, which are monitored twice weekly. So if BUN levels are between 10 to 16 milligrams per deciliter, this is taken as optimal. Whereas if BUN level is less than 10 or more than 16, this is considered either low or high. So if on a baby with fortification, we find that the BUN level is less than 10, this means that there is inadequate protein accretion, and hence the approach would be to increase the protein intake by increasing the strength of fortification. So if, for example, we are giving the standard concentration of 1 gram to 25 ml, we may start using 1.5 gram to 25 ml instead of 1 gram. On the other hand, if you find that the BUN level in the baby is more than 16, then we may even decrease the strength of fortification. So we may decrease the concentration. So we can do this usually until a strength of, twice the standard fortification. So up to 2 sachets of 1 gram can be mixed with every 25 ml. The other approach is to use targeted fortification, where a human milk analyzer is used to measure the quantity of calories and proteins in human milk. So there are bedside human milk analyzers that are available and they are required, and they may be labor intensive though. But supplementation is done according to the consideration of individual baby's requirements. So for example, if the human milk analyzer shows that 100 ml of preterm mother's milk had only 1.5 gram of protein, and based on the baby's weight, we needed to provide 2 grams, then additional 0.5 grams is the content of protein that needs to be provided per 100 ml. So this is calculated on an individual basis, and appropriately the content of fortification is decided. Now, one of the important limitations of various types of human milk fortifier has been cost. So this study from AIMS, performed by one of the residents there, and published recently in JAMA Pediatrics, looked at preterm formula as a potential fortifying agent, as a multi-component fortifying agent. So the study randomized preterm infants to receive either preterm formula as fortification, which was also added similar to HMF at 1 gram per 25 ml of human milk. So preterm formula was made into appropriately sized sachets. And the other group was randomized to receive regular human milk fortifier added to mother's own milk. So this was a non-inferiority trial that looked at in-hospital weight gain as the primary outcome. So they found no significant difference in the weight gain achieved in gram per kg per day between the group of babies fortified with either preterm formula or with regular human milk fortifier. Interestingly, the study found that the number of episodes of feeding intolerance, calculated as number of episodes per 1,000 patient days, was significantly lesser in the group of babies who received preterm formula as fortification. Of course, this is a subjective outcome. It is relatively difficult to make this outcome objective, although this was defined in a very standard fashion in both the groups, and this is an interesting observation. What the study shows is that preterm formula can be possibly used as an alternative to human milk fortifier, the HMFs that are traditionally available, with no significant effect on the short-term anthropometric gains, neither in hospital weight gain in grams per kg per day, nor in the linear growth parameters such as length or head growth. Fortification with preterm formula is not inferior to regular human milk fortification, and it reduces the incidence of feeding intolerance and the need to withhold fortification. So beyond this, the other important benefit is that fortification of preterm formula would be less expensive and hence might be a better option for fortifying breast milk in these neonates. The other important area of research in enteral nutrition is with regards to enteral feeding in babies with abnormal umbilical arterial Dopplers. We know that preterm newborns less than 35 weeks with absent or reversed end diastolic flow have a 2.1 times higher risk of developing necrotizing enterocolitis. And ADEPT trial, published in 2012, was a randomized controlled trial that compared early versus delayed initiation of enteral feeding in babies with abnormal Dopplers. Early was defined as feeding initiated at between 24 to 48 hours, whereas in the other arm, the babies were initiated on feeding between 4 to 6 days. This was the standard practice at that point of time. So the ADEPT trial showed that there was no difference in the incidence of NEC between these two approaches. When we look at the percentage of babies who were established on full feeding, as expected, the babies who received early feeding had a shorter time to achieve full feeding, and this was significantly lower than the time needed to reach full feeding in the regular feeding arm. So to summarize the recent advances in the domain of enteral feeding, we know that as per the SIFT trial, faster advancement in enteral feeding does not increase the incidence of NEC, and faster is defined as 30 ml per kg per day increment. This is the first outcome. The benefits of minimal enteral nutrition have already been shown in multiple earlier trials. The next important area is probiotics. So in probiotics, we have seen that multi-strain combinations of probiotics are much more effective than single-strain probiotics. And particularly the benefits are reduction in NEC stage 2 and 3, reduction in mortality, and reduction in all-cause in sepsis. Other favorable benefits are reduction in the time to reach full feeds and episodes of feeding intolerance. So this has been shown to be consistent across the type of milk that is being fed, both formula fed and breast milk fed babies. It has been consistent across the baseline incidence of necrotizing enterocolitis in different units. Strain specific data is now evolving, and we looked at a beneficial combination of three strains of bifidobacterium and one lactobacillus species, which has been found to be associated with all these benefits. When it comes to fortification of babies who are fed human milk, again, there is some upcoming role of early fortification, which we did not discuss in detail. But NNF CPG guidelines also recommends now that we can start fortification earlier than 100 ml per kg per day, starting from volumes of 50 to 80 ml per kg per day. Even lower volumes to start fortification have been studied. So it seems like earlier fortification is feasible and doesn't necessarily increase the risk of NEC. Now, fortification in general is now evolving towards individualized approaches where one tries to look at the blood urea nitrogen levels, or at targeting optimal levels of macro and micronutrient intake based on human milk analysis. And finally, we have seen that even in babies with abnormal Dopplers, as seen in ADEPT trial, early feeding can be safely started without increasing the risk of NEC and with a shorter time required to reach full feeds. So we'll move on to the next area where we shall discuss recent trials, which is hemodynamically significant PDA. Now, the most effective treatment as per recent network meta-analysis for PDA has been shown to be high-dose brufen. So among various treatment approaches, we know that we have indomethacin, which is as of now not available in India. So we have a high-dose indomethacin and another regimen, the regular regimen and a high-dose regimen here. And then we have brufen. Again, IV brufen is available in some countries, but oral brufen is regularly available in India. Oral brufen again has a higher dose regimen and a lower dose regimen. And then we have paracetamol, which is a peroxidase inhibitor. Paracetamol has come in relatively recently, but now we have a lot of evidence to recommend the efficacy of paracetamol in closure of HSPDA. All these three pharmacological agents have been found to be having nearly equivalent efficacy, which is usually ranging between 70 to 80% for achieving closure of a hemodynamically significant PDA. Paracetamol has been found to be safer than the other two approaches, particularly with lesser risk of most of the serious complications like mesenteric ischemia, acute renal failure that are seen with indomethacin. Indomethacin has been extensively evaluated in a prophylactic approach started early. This came in from the TIP trial. Although a prophylactic approach to use indomethacin has been associated with better rate of PDA closure, it has not translated into reduction in BPD. In fact, the TIP trial showed that the group of babies who never had PDA and who had received prophylactic indomethacin were at higher risk of developing BPD. So prophylactic indomethacin approach has been dropped for this reason. Although prophylactic indomethacin had one attractive sort of positive feature, which was reduction in the risk of intraventricular hemorrhage. Again, this is controversial because most of this reduction involved milder grades of IVH, grade 1 and grade 2. And this reduction in IVH again did not translate into benefits in long-term neurodevelopmental outcomes. So with this background, we shall now discuss what are all the newer research areas in PDA. So this is a network meta-analysis that was published in JAMA in the year 2018, and it evaluated the role of different pharmacological measures for achieving closure of a HSPDA. So among all the different drugs that we just saw, this network meta-analysis showed that the most beneficial or highly ranked approach was to use high-dose brufen. High-dose brufen was defined as a dose of, initial dose of 15 mg per kg, 15 to 20 mg per kg, followed by 7.5 to 10 mg per kg, given at a gap of 12 to 24 hours. So this is one area. The other very controversial area in PDA has been the identification of HSPDA itself. So what qualifies for hemodynamically significant PDA? So here in 2009, Patrick McNamara and his group came up with this classification based on various echocardiographic parameters. What has been found across research is that not only is identification of PDA based on the transductal diameter in the 2D ductal view, which is a short axis parasternal view, important, but also to recognize various parameters that indicate pulmonary overcirculation and systemic hypoperfusion. So finding a large PDA with a size of more than 1.5 mm in the ductal view alone doesn't amount to a significant PDA. PDA that is associated with signs of pulmonary overcirculation or systemic hypoperfusion only would qualify for treatment. These signs are an elevated left atrial to aortic ratio, which is measured usually in the long axis parasternal view or LAPS view, M mode view, which compare the ratio of the left atrial to aortic root ratio. So if this is more than 1.6, or if the left ventricular aortic root ratio, again similarly measured in the M mode long axis parasternal view, if this is usually greater than 2.2, or finding a transmittal E by A ratio on transmittal Doppler if this is greater than 1.5, which is also called as pseudo normalization of the EA ratio. So all these signs, finding one or two of these signs, shortening of the IVRT or isovolumic relaxation time, which is the time between the mitral and aortic valve opening. The LVSTI, all these parameters also help us to decide whether the PDA is accompanied by signs of pulmonary overcirculation. Likewise, if we find signs of systemic hypoperfusion, also it might indicate a PDA which is significant, such as retrograde diastolic flow in continuous Doppler in the descending aorta, or finding absence or reversal of diastolic flow in the vessels of the descending aorta, finding a elevated left ventricular output, which is defined as more than 314 ml per kg per minute, or elevated LVO by SVC ratio. So increase in the left ventricular output because of the large PDA and decrease in the SVC flow because of the shunt across the PDA. So the LVO by SVC flow ratio is going to go up in PDA. If this crosses 4.5, again, this is taken as a sign of a large PDA. We will move on now to ROP, which is another interesting area with a lot of new trials. So ROP in a preterm baby is caused because of the transition from the normal and relatively hypoxic intrauterine environment, where the average saturations in the aorta would be only around 45%, to an environment where the baby is suddenly exposed to additional oxygen concentration. So this is categorized into phase 1 and phase 2. Phase 1, where increased oxygen exposure will lead to sudden arresting of the vascular growth, and phase 2, where decreased oxygen will lead to neovascularization. So this the pathogenesis of ROP is important for us to understand the different mechanisms for restricting or limiting the progression of ROP. So in the first phase, the baby gets exposed immediately after birth to increased oxygen tension. This results in sudden cessation in the production of growth factors like VEGF and angiopoietin, which results in sudden obliteration of the normal retinal vessels. This leads to an area of peripheral retinal hypoxia, and which in turn leads to increase in the levels of growth factors like VEGF, angiopoietin or insulin-like growth factor from the peripheral area of the retina, which is avascular, leading to neovascularization and fragile retinovascular proliferation, leading to ROP and retinal detachment. So it was believed that in the second phase, if we supplement oxygen, this might lead to cessation of the progression of ROP, and this was the physiology behind the STOP-ROP trial, where babies were provided additional supplemental oxygen as therapy to limit the progression of ROP. However, the STOP-ROP trial, which was published way back in 1999, actually showed that giving additional supplemental oxygen did not stop progression of ROP, but in fact, it resulted in a lot of other unfavorable benefit and unfavorable outcomes, like increasing the incidence of bronchopulmonary dysplasia and prolonged need for supplemental oxygen, home oxygen therapy, etc. So this approach was immediately abandoned. But researchers still continue to look at other strategies that could be useful for either preventing ROP or treating ROP once it has set in. So conventionally, the treatment of ROP, once the baby's retina has been screened and ROP has been ascertained, was traditionally in the form of cryotherapy, and later the advent of laser therapy came in, where laser was used for ablating the peripheral retina, from where the stimulus for production of these angiopoietic growth factors is being emitted. When we look at the conventional laser therapy, the first two pictures on top give us an idea of what happens with conventional laser therapy. So when one lasers the baby's retina, it results in the cessation of production of growth factors from the peripheral part of the ablated retina, which is avascular. But the side effect might be that there may be an abrupt cutoff in the ongoing retinal vascularization. So even ongoing normal retinal vascularization may abruptly kind of cut off when we give laser therapy. So you can see in this figure how a baby who has previously received laser therapy has literally no peripheral retinal vascularization, and these arrows indicate the extent of the vessel growth at the point when the laser was provided. So not only abnormal neovascularization is arrested with laser therapy, even normal retinal vascular growth can be arrested with laser therapy. In contrast, when we use vascular endothelial growth factor antagonists like bevacizumab, which are drugs, which are agents used in the management of adult diabetic retinopathy, researchers found that there was ongoing growth of the retinal vessels even in peripheral regions of the retina. So we can see that this is the retinal vessels that are starting, and then we can see that there is good degree of peripheral retinal vascularization as well. So this idea gave rise to the BEAT ROP trial, which evaluated 150 babies or 300 eyes to be randomized to receive either bevacizumab, which is anti-VEGF agent, versus the conventional treatment with laser, and looked at the adverse retinal outcomes. So this was a study that was published by Helen Mintz-Hickner and group. The dose of bevacizumab that was used was 0.625 milligrams in 0.025 ml, which was injected intravitreally. So what the study found was that in zone 1 ROP, so the two figures here represent the progression to develop abnormal visual outcomes in zone or recurrence of ROP actually. So this study actually shows, this figure actually shows recurrence of ROP in the babies who had zone 1 ROP on the left side and zone 2 posterior ROP on the right side. So in those babies who had only zone 1 disease, so zone 1 is the most central part of the retina, the area extending from the macula to a radius of 2 disc diopters around the macula. So this area had significantly lesser progression to ROP requiring retreatment when treated with bevacizumab. With a relative risk of 0.09 with confidence intervals of 0.02 to 0.43. And so we can see that 27% of babies who had received conventional therapy or laser therapy had recurrence of ROP, whereas 0% babies who received bevacizumab progressed or had recurrence of ROP. However, when we look at zone 2 ROP, there was no significant difference when we used bevacizumab. So recurrence of ROP before 54 weeks of post-conceptional age was significantly lesser by using bevacizumab, and this arose from the findings of the BEAT ROP trial. Moving further, we had another newer anti-VEGF agent, which is ranibizumab. This was tested with the newer Rainbow trial, which was published by Andrea Stahl and her group in Lancet 2021. So this study compared 3 arms. So it used ranibizumab itself in 2 doses. In one group, it tested a dose of 0.2 mg, and the other group received 0.1 mg. So there was a high dose ranibizumab and a standard dose ranibizumab arm, and the third group was randomized to receive conventional laser therapy. So again, this study included babies with birth weights of below 1,500 grams who were regularly being screened for ROP, and ROP classification was done based on the ET-ROP or early treatment for ROP study. So when the study investigators compared these 3 arms, it was found that ranibizumab given at a high dose of 0.2 milligram was more effective than 0.1 mg as well as laser for treating ROP. So in the 225 babies who were part of the study, successful treatment was possible in 80% of the babies in the ranibizumab 0.2 milligram arm, when compared to 75% in the 0.1 milligram ranibizumab arm and 66% in the conventional laser arm. So this is what we just saw. The overall treatment success rate was better with higher dose of ranibizumab. When analyzed separately in babies between 25 to 26 weeks, less than 25 weeks, and in babies who are more than 26 weeks, the success rate for ranibizumab high dose was almost similar to ranibizumab. In the less than 25 weeks, there was not much of difference. So when we looked at these two studies, Rainbow study included all forms of early treatment ROP, type 1 ROP, apart from this one stage, zone 2, stage 2 plus ROP. So if you look at type 1 ROP, it might include any ROP associated with plus disease in zone 1. And then in zone 2, it includes stage 2 and 3 with plus disease. So ETROP defines ROP as type 1 and type 2 based on the stage, the zone, and the presence of plus disease. So anything which is classified as type 1 ROP requires treatment. So Rainbow study included all babies who had treatable ROP, which is type 1 ROP. Whereas the BEAT ROP study only looked at babies who had stage 3 plus disease in zone 1, as well as posterior zone 2. And that too, they found the benefits of bevacizumab only in zone 1 disease, where bevacizumab was associated with lesser risk of recurrence of ROP. And the timing at which the babies were evaluated was also slightly different. In Rainbow study, the outcomes were evaluated per patient 24 weeks after the first treatment at a mean age of around 60 weeks post-conceptional age, whereas BEAT ROP only ascertained each eye to 54 weeks of post-menstrual age. So to summarize, if we look at all studies that have looked at anti-VEGF therapy in ROP, one may say overall that the poor structural outcomes, particularly partial or complete retinal detachment, may occur with a similar risk in both the groups. So you can see that in non-APROP babies, as well as in babies with APROP, the risk of adverse structural outcomes may be similar with anti-VEGF therapy or with conventional cryo or laser. But definitely the progression to refractive error or very high myopia at or after 12 months of age was significantly lesser in babies treated with anti-VEGF therapy. This seems to be mostly because of the continuation of ongoing normal retinal vascular growth in those babies who are treated with anti-VEGF therapy. So the use of intravitreal bevacizumab or ranibizumab when used as monotherapy reduces the risk of refractive error during childhood, but does not reduce the risk of retinal detachment or recurrence of ROP in infants with type 1 ROP. While the intervention might reduce the risk of recurrence, specifically in babies with zone 1 ROP, it may potentially result in higher risk of recurrence requiring retreatment in zone 2. So this was primarily from the BEAT ROP study. And intravitreal pegaptanib in conjunction with laser therapy also reduces the risk of retinal detachment. The other newer anti-VEGF therapy, which we must be aware, is this drug. In addition to bevacizumab and ranibizumab, aflibercept is another VEGF antagonist that we all should be aware of. So with regards to ROP, what we have seen is we have two important trials that have spoken about anti-VEGF antagonization in the treatment of ROP or in preventing its progression. The BEAT-DROP trial that looked at bevacizumab definitely showed that in babies with zone 1 disease, there was lesser risk of recurrence when we used intravitreal bevacizumab when compared to laser. But in zone 2 disease, it didn't make a difference. Now, as per the Rainbow trial, we know that ranibizumab, when used at 0.2 milligram dose intravitreally, was associated with better treatment success rate when compared to ranibizumab 0.1 milligram and conventional laser. But when we put all the studies together, what we know is that anti-VEGF therapy or conventional laser therapy may have relatively same incidence of adverse structural outcomes, particularly retinal detachment. But one important advantage is lesser incidence of refractive errors or high myopia with any of the anti-VEGF agents when compared to conventional laser treatment. Some important studies in the area of perinatology So here we come to the maternal antenatal steroid coverage. So there is, we all know very well that antenatal steroid coverage in the form of 2 doses of betamethasone 12 milligrams or 4 doses of dexamethasone 6 milligrams, of which the last dose is given at least 24 hours prior to the delivery of the baby, is associated with a lot of neonatal positive outcomes like reduction in RDS, reduction in all-cause mortality, reduction in NEC, and reduction in IVH. Now, there has been a lot of debate about which steroid is better, betamethasone or dexamethasone, particularly because betamethasone in India is only available as beta phosphate, which is different from the conventionally tested and tried betamethasone combination of phosphate and acetate available as celestone in the Western literature. So, Government of India has recently recommended in India that dexamethasone is the preferred antenatal corticosteroid. Asteroid was one recent trial that compared maternal intramuscular dexamethasone versus betamethasone. There have been not many trials directly comparing antenatal dexa versus beta earlier, and Asteroid was a multi-center double-blind randomized controlled trial which did so. And what did it find? It found that mothers receiving either of the antenatal steroids had similar neonatal outcomes. The incidence of hypertension was slightly more with betamethasone, 41% versus DEXA, 32%. And cesarean section rate or operative delivery rate was slightly higher with betamethasone. So barring these two maternal outcomes, which can be viewed with its own pros and cons, there was no major difference in the neonatal outcomes between betamethasone and dexamethasone. The next very important area of research was on the use of oral low-dose aspirin in nulliparous pregnant women who did not have any risk factors. So aspirin trial, the name of the trial itself was aspirin. This was a randomized, again, multi-country, multi-site, double-blinded placebo-controlled trial, where in one group of mothers, low dose of aspirin was given. And in other group, a similar looking placebo was used. So some important aspects of the aspirin trial was it enrolled low-risk mothers. These were not mothers who had high risk of PIH or other morbidities. These were low-risk nulliparous mothers, primiparous mothers. And they started enrollment very early, from 6 plus 0 weeks of pregnancy to 13 plus 6 weeks of pregnancy. So in early first trimester, after an ultrasound confirmation of viable pregnancy and confirmation of gestational age. Participants from multiple countries were involved, including 2 sites from India. Now, aspirin trial used 81 milligram dose of oral aspirin given once daily. And it found a very, very important 11% relative risk reduction in overall risk of prematurity. So aspirin stands for aspirin supplementation for pregnancy indicated risk reduction in nulliparous trial. So this is the expansion of the aspirin trial. The other important intervention that has been shown to reduce prematurity rate is progesterone. So we'll discuss about progesterone also in a while. This is the outcome table from the aspirin trial. So we can see that a large number of mothers were enrolled, 5,780 in the aspirin group and 5,764 in the placebo group. The relative risk for prematurity overall was 0.89, which indicated 11% relative risk reduction in the incidence of prematurity. The p-value is also statistically significant. The 95% confidence intervals did not cross 1, indicating that this was a significant reduction in prematurity. There were some other beneficial outcomes that were also seen in the tested babies. A reduction in overall perinatal mortality, which is the combination of stillbirths and early neonatal deaths. There was also a reduction in early preterm births, that is less than 34 weeks, and a trend towards reduction in extreme preterm delivery. Okay, now what about progesterone? Progesterone may reduce gap junction formation and may antagonize oxytocin, which may lead to a relaxation of smooth muscles, and inhibit progression of preterm labor. It will maintain cervical integrity also. So cervical ripening also might be inhibited by progesterone, as well as due to its anti-inflammatory effects. Progesterone may potentially reduce inflammation or cytokine storm, which may play an important role in progression of preterm delivery. Progesterone, when given for this purpose, for prevention of premature delivery, has been found to be ineffective in twins. And it may be only effective in singleton mothers who are at risk of preterm labor, indicated by previous preterm labor, elevated fetal fibronectin, or shortening of the cervix. Short cervix defined as length less than 25 millimeters. So vaginal progesterone has been found to reduce preterm births delivery below 34 weeks with the odds ratio of 0.43, and also overall preterm deliveries less than 37 weeks with OR of 0.51, which is 49% reduction in overall preterm deliveries. So in singleton pregnancies, the other intervention that is found to be useful is cervical encerclage, which seems to be effective in mothers who had cervical shortening, as well as mothers with previous history of preterm birth. So if there was both these 2 points, so if there is previous history of preterm labor and evidence of cervical shortening as indicated by short cervix in the current pregnancy, then these were the mothers who benefited maximally from cervical encerclage. Cervical encerclage in women with short cervixes with no previous preterm births showed no advantage. And in twin gestational age, cerclage births for short cervix was actually associated with an increase in preterm birth. So it's not effective in twin pregnancies. Now we move on to the last domain, which is neuroprotection. So in the neuroprotection domain, what sign of MRI? What sign on the MRI is important for long-term outcome in HIE? It is Plick sign, or posterior limb of internal capsule sign. Therapeutic hypothermia. This is something we all already know now. For moderate or severe encephalopathy, that is stage 2 or stage 3 encephalopathy, reduces the risk of mortality and abnormal neurodevelopmental outcomes if given less than 6 hours after birth, and to be continued for 72 hours. So 72 hours and less than 6 hours after birth. And the target temperature must be 33 to 34 degrees Celsius, or 33.5 plus minus 0.5. Magnetic resonance spectroscopy markers of poor outcome in HIE. So MRS, as shown by a recent systematic review, has been found to be one of the most sensitive and specific markers of abnormal outcome in HIE, even better than T1 and T2 weighted MRI. And in MRS markers, particularly lactate by NAA ratio of more than 0.09. This is found to be very sensitive specific. Likewise, NAA by choline ratio, which is decreased, is also found to be a good marker of HIE. There are additional newer adjuvant drugs which are also found to be neuroprotective, particularly when combined with hypothermia. And some of these drugs are xenon, topiramate, and erythropoietin. So a lot of body of literature is coming up on the adjuvant neuroprotective agents. So levetiracetam, is it an effective first-line therapy for neonatal seizures? Controversial. We would rather answer false if we read the NEO-LEV2 trial. Again, both positives and negatives, both pros and cons are there. But this large NEO-LEV2 showed that levetiracetam is actually inferior to phenobarb when used as first-line anti-seizure drug in neonates. And the 4 major criteria, sorry for the overlap, as defined by the AAP-ACOG are for defining intrapartum hypoxia are pH less than 7 in the cord umbilical gas, which can be either metabolic or mixed, but not purely respiratory acidosis if present. Decreased Apgar scores of 0 to 3 for longer than 10 minutes, for longer than 5 minutes, sorry. Neurological manifestations of in the form of seizures, coma, and hypotonia in the baby, and the presence of MODS or multi-organ dysfunction. So here, what is newer research in neuroprotection? Therapeutic hypothermia has already been recommended as standard care in newborns with sustaining asphyxia and those with moderate to severe encephalopathy. Ample evidence from the high-income countries. Now, HELIX trial, which was published in 2021, was a multi-center randomized trial which looked at therapeutic hypothermia using a servo-controlled cooling device. Not entirely servo-controlled. Cooling part was servo-controlled, but rewarming was manual in the equipment that was tested in Helix trial. It enrolled multiple high-volume centers in India. And this Helix trial brought in a lot of controversy. It randomized 408 infants with moderate to severe encephalopathy to receive cooling versus the control standard treatment. Now, when they compared the outcomes, there was no difference in the outcome of death versus death and disability. No significant difference. But when we looked at death alone, mortality alone, the red bar represents the control arm, the blue bar represents therapeutic hypothermia arm. So there was significantly higher incidence of death in the therapeutic hypothermia arm, making the investigators recommend against therapeutic hypothermia in low middle income countries. Of course, this came with a lot of controversies. The authors did not necessitate the presence of severe metabolic acidosis in the cord blood gas or immediate postnatal blood gas. So this was done for pragmatic reasons, in the anticipation that most of the setups in busy high volume centers catering to asphyxia may not have routine access to blood gases. But this may have resulted in enrollment of newborns with partial and prolonged hypoxia and not really acute hypoxia. Because the study did not mandate the necessity of finding severe metabolic acidosis in the cord or immediate postnatal blood gas. So this may have resulted in inclusion of more outborn babies with subacute or partial prolonged hypoxia due to the deficient perinatal or prenatal care itself. So babies could have suffered hypoxia for much more longer periods without our knowledge, because a lot of these included babies were outborn. And we might have started cooling many hours after the primary hypoxic insult, so much more than 6 hours. This also goes with the MRI finding of more periventricular leukomalacia in the infants in Helix trial. So we know that periventricular leukomalacia is usually found in preterm infants suffering from hypoxia, and this can be also seen in term infants who suffer from partial and prolonged hypoxia. If they had had babies with acute severe hypoxia, we might have expected more of thalamic and basal ganglia injury, which was not the case in the Helix trial. More than 70% of infants included in the Helix trial were actually outborn. They had early seizure at randomization, indicating that therapeutic hypothermia was probably started after the initiation of secondary injury, and hence therapeutic hypothermia could not have been successful in preventing the onset of secondary energy failure. Hypothermia-mediated liver decompensation also could have been a possible reason for the findings of the Helix trial. So, in effect, what do we understand? The Helix trial does not discourage us from using therapeutic hypothermia even today as neuroprotective strategy in asphyxiated neonates fulfilling the other inclusion criteria, provided we are able to ensure that the baby did have regular intrapartum monitoring and did genuinely have acute onset of hypoxia. And therapeutic hypothermia was initiated within 6 hours of the insult so that it could prevent secondary injury. And also therapeutic hypothermia should be provided along with other important modalities of supportive care. The other important neuroprotective adjuvant therapy has been erythropoietin, which has a number of beneficial effects by which it can help in therapeutic hypothermia, starting from reduction in oxygen consumption and storage in the hypoxic brain, and mitigating hypoxia-induced nitric oxide surge and excitotoxicity as well as inflammation. These are all different trials that looked at erythropoietin. And this table actually gives us the doses in which they were used and the timings of administration. Most trials found improved long-term outcomes after erythropoietin treatment in infants with moderate HIE and not necessarily in babies with severe hypoxic ischemic encephalopathy. And hence, this is a very promising new intervention Studies have also looked at erythropoietin as an adjuvant or add-on therapy along with therapeutic hypothermia in birth asphyxia. And this combination also was found to be not only safe but effective. So in hypothermia, we have seen about HELIX trial, and the HELIX trial showed some adverse effects with therapeutic hypothermia in low middle income countries, but this may not be necessarily applicable in all setups in low middle income countries. We have also looked at adjuvant neuroprotective modalities, particularly the evolving role of erythropoietin either as a standalone measure or in combination with hypothermia for neuroprotection. Another important area of research in neonatal neurology has been comparison of phenobarbital versus levetiracetam for the treatment as a first-line anti-seizure drug in treatment of neonatal seizures. Both these drugs have been found to be either equally efficacious, or some studies may have shown levetiracetam has been even superior in seizure control. However, the NEO-LEV trial published by Sharp et al. In Pediatrics 2020, which included both clinically evident as well as EEG diagnosed seizures, which is the gold standard for diagnosing neonatal seizures, did find that phenobarbital resulted in 80% seizure control, whereas only 28% in levetiracetam at 24 hours post initiation of either drug, giving a lot of evidence in favor of continuing to use phenobarbital as the first-line anti-seizure drug. This also goes in lines with the International League Against Epilepsy guideline, which continues to recommend phenobarbital as the first-line anti-seizure drug. So to summarize, in neurology, we looked at the newer HELIX trial of hypothermia in low middle-income countries. We have also looked at therapeutic hypothermia plus or adjuvant neuroprotective mechanisms, particularly the role of erythropoietin and xenon. And then we looked at the controversy of phenobarbital versus levetiracetam as first-line drug, and how the NEO-LEV-2 trial still showed that there is some worth in using phenobarbital for better seizure control, although levetiracetam has some attractive physiological advantages like lesser apoptosis and lesser brain injury. Some other areas of evolving research are thresholds for platelet transfusion in preterm infants. This was the findings of Planet 2 trial published in NEJM 2019. It enrolled 660 infants, preterm infants less than 34 weeks, with thrombocytopenia, and it studied two platelet thresholds. The low threshold for transfusion group, where infants were transfused if platelet count dropped to below 25,000 per cubic millimeter. And in the high threshold group, preterm infants were transfused at or below counts of below 50,000 per cubic millimeter. And what did we find? We found that the overall incidence of death or major bleeding episode through the trial from birth till day 28 was cumulatively higher in the high threshold group. So despite giving platelets at below 50,000 itself, we actually saw higher incidence of death and bleeding when compared to only 19% in the low threshold group. So it actually gave support to the idea that giving platelet transfusion alone may not prevent bleeding. So bleeding in preterm infants may be a combination of multiple other factors. Particularly if you look at IVH, it is usually because of the fragile nature of the germinal matrix, the fragility of the vessels, the thin single layer endothelium surrounding the capillaries, and rapid fluctuations in the mean arterial pressure and cerebral blood flow rather than thrombocytopenia. In fact, giving platelet transfusion may potentially result in adverse lung outcomes, as was seen that there was a higher incidence of bronchopulmonary dysplasia or death as a post-hoc outcome in the babies who received platelet transfusions at a count below 50,000. Another important trial has been the I-KMC trial, or the immediate initiation of KMC trial. Now, this study, in which Dr. Suman Rao ma'am was the principal investigator, looked at a population of low birth weight babies between 1 to 1.8 kilograms at birth. And they were randomized to receive IKMC, which was immediate onset of KMC in the enrolled infants within around 2 hours of birth, where a standard onset of KMC and where KMC was started as a standard practice after stabilization of the preterm baby, and they looked at outcome as the primary mortality as the primary outcome. In the immediate KMC group, infants were initiated on skin-to-skin contact at 1.3 hours from birth, when compared to 53 hours from birth in the control arm. The study had a very robust study protocol, and when they compared death between enrollment and day 28, it was found that immediate onset KMC was associated with much lesser incidence of mortality, 12% in the IKMC arm versus 15.7% in the standard KMC arm. This 3.7% absolute reduction in mortality translated into a 25% relative reduction in the risk of dying between birth and 28 days from enrollment. So this could have resulted from multiple benefits, including the early initiation of breastfeeding, better breast milk production, and higher involvement of mothers in the care of the baby. And the IKMC trial, in fact, led to the idea of MNICUs, or Mother Neonatal Intensive Care Units, where maternal beds needed to be placed close to the NICU cribs. So this requires an entire change in our NICU design if we have to actually implement this major landmark intervention. The last study that we'll discuss today is this cluster RCT published in Lancet, that looked at family-centered care among preterm neonates born at below 34 weeks of gestational age, including 26 tertiary NICUs from different countries. They enrolled babies who required no or very low level of respiratory support, and randomized them into 2 arms. This was a cluster design. So in the family-centric intensive care arm, parents were to be present for at least 6 hours daily, and they would attend educational sessions and would be actively involved in the care of the infant. Whereas in the standard care arm, the parental involvement would be defined as per the standard practices. And what did the study find? The study found that the average change in the Z-score, or in the daily mean weight gain, was significantly higher in the family-centered care arm. So there was better weight gain, both when measured as mean change in the Z-score or as average weight gain per day. It was 26.7 grams daily weight gain versus 24.8 in the standard care arm. There were no other significant differences in most of the other outcomes. So these were all some practices which families were involved in. So with that, I thank those of you who could attend this webinar. And if there are any questions, you can please list it in the comment section. Thank you so much.